All right, good afternoon. Welcome everybody to Chicago Check's virtual community conversation on Toolkit to Quit, effective tools to quit smoking after a cancer diagnosis. I'm Alicia Kalami and I'm a community health educator with Chicago Check through NEIU. And this event was brought to you by Chicago Cancer Health Equity Collaborative, also known as Chicago Check, which is an NIH-funded grant that collaborates with Northwestern, University of Illinois at Chicago, Northeastern Illinois University, and various community partners. We aim to support cancer health equity in Chicago through research, training, education, and community engagement. Also wanted to give a special thanks to our speaker today, Sarah Clark, who and all of her collaborations with today's session. So thank you so much. But before I pass the floor on to our wonderful expert for today, just a couple housekeeping rules. We will have a Q&A and discussion at the end of the session. So while others are talking, we will unmute everybody and everyone will be able to have that open discussion. But just keep yourself muted while others are talking so we can all hear each other. And then throughout the event, if you have any questions, comments, anything like that, please feel free to enter them in the chat. We have staff that are monitoring it. I'm also joined today by my coworkers, Melissa and Edgardo, to help moderate. So without further ado, I'll go ahead and pass the floor on to our wonderful speaker, Sarah. Thank you so much.
All right, great. Thank you. Let me share my screen here. All right, can everyone see that? Perfect. Yes. Good. So hi, everyone. So thanks so much for joining me here today for Toolkit to Quit, effective tools to quit smoking after a cancer diagnosis. Before we get started, I just wanted to introduce myself. My name's Sarah Clark. I'm a tobacco treatment specialist and behavioral counselor. I work in supportive oncology for the Lurie Cancer Center Tobacco Cessation Program at Northwestern. And I just wanted to take a quick moment for thanking Chicago Check for putting on these virtual conversations. They're so important to have, and it's really cool to be a part of one. And I also want to say a special thanks to some really key people in PrevMed and at the Lurie Cancer Center, Dr. Heitzman, Dr. Pierman, Dr. Kircher, Dr. Plantanius, really for their continued support and advocacy of tobacco treatment. Really without them, I wouldn't have received the training that I have and the clinical experience that I have that, has given me the knowledge that I'm sharing with you now. So with that being said, let's move on. This is just a brief overview of what we'll be covering today. So we'll start with, how we talk about smoking, and we'll do a little bit of an exercise there. Then we'll get into smoking prevalence, some of the health impacts of smoking, particularly in the context of disparity in cancer treatment outcomes. And then the second half of this presentation will really address tobacco dependence. And I hope you are able to leave this conversation today having some tools in terms of a better understanding of pharmacotherapy and some foundational understanding of behavioral counseling to begin your journey to quit smoking if you're interested in quitting and you are a current smoker, or if you're trying to assist a loved one in a quit attempt. So for this exercise, I'd love to get some audience participation. So feel free to type in the chat or unmute yourself and blurt out the first thing that comes to mind when you're viewing this ad. This is a print ad for Newport menthol cigarettes. What words or emotions come to mind when viewing this advertisement, and how are the people in this image portrayed? Vacation, relaxation, happy, friendly, fun at the beach, absolutely. Absolutely. So, you all hit on, some really youthful, absolutely. So, everyone's hitting on some really great themes in this ad, right? These just happen to be people who are having a fun day at the beach. They're youthful, they're fit, they're active. Not one person in this advertisement is even smoking. Um, the Newports are really secondary. They're sort of tucked up here in the corner. And everyone is smiling and you can see their faces, right? These are people first. They're having a good time and they happen to be people who also smoke cigarettes. Now, I want to contrast that with this image from the latest CDC Tips from Former Smokers campaign. And in particular, if you are someone in the audience who currently smokes or you're a former smoker, I would especially like to hear from you and some of your thoughts on, how does viewing this image make you feel? Intense. It's an intense image. Yeah, absolutely. Right. Depressing. Hmm. Absolutely. Yeah. So, it's a powerful image, right? But if we contrast it with the Newport ad, this woman, Annette, she's presented to us as a former smoker. Um, and her disease is really presented first and foremost, right? Her lung cancer. We can't even really see Annette's face in this photo. She is, identified as a smoker and as someone with lung cancer. Her humanity, her personhood is not really at the forefront of this ad. And also, the quote, the overlying quote here: after you have a lung removed, take short breaths. Yikes. This is, in my opinion, it's pretty condescending. And as a tobacco treatment specialist, saying something like this to a patient really goes against everything you're taught about treating tobacco dependence. And it's not really sharing anything new. Is this ad really giving you new information about the health impacts of smoking? Not particularly. So I would argue it's not particularly constructive, and it's really almost hopeless, a little bit devoid of hope for, if you're someone who is a current smoker and you view this ad, it's not necessarily going to make you feel motivated. It really may make you feel, a little bit depressed and hopeless. And so, this isn't uncommon. And historically, the healthcare system and public health as well have adopted the approach that if we just keep telling people the negative health impacts of smoking, they'll stop smoking. And that's not really how nicotine addiction works. And I would argue that, when we start viewing tobacco abuse as a personal choice, we're taking the side of big tobacco. And there's a legacy of this practice. So the choice as blame model. So in the 1980s, there was a wave of lawsuits against tobacco companies from people who smoked cigarettes, and they started filing lawsuits against big tobacco for getting cancer and a variety of other health issues. Now, Big Tobacco responded by, of course, spending a lot of money on attorneys and developing good legal strategies to defend these lawsuits. And so, what the attorneys figured out was if they could focus the blame on the individual plaintiff, and they argued that everyone who smokes understands the health risks associated with smoking. So people who choose to smoke have no one to blame but themselves for the negative health effects, right? They choose to smoke despite knowing the risks. When we look at individuals and the choices that they make to smoke, we're really neglecting a lot of things. So, what happens when we zoom further out and we look at trends in tobacco use? Well, we know that over 90% of tobacco users begin smoking before the age of 18 when their brains are not yet fully developed. We ignore that nicotine is highly addictive and it causes long-term structural brain changes. It also neglects the fact that tobacco companies strategically market products with increased advertisements and price promotions in areas where people have the greatest barriers to tobacco treatment. So let's zoom further out and look at some trends. So smoking in the United States. If you look at this figure here on the left, it looks pretty optimistic, right? So in 2005, we were at a little bit over 20% smoking prevalence. And by 2015, we're down to about 15%. Now, this diagram here only shows combustible cigarette usage. But if we take into account all tobacco products, particularly the increased prevalence of the usage of electronic cigarettes, we see that about 20.8% of American adults are still using tobacco. And so that 20.8%, that's from 2019. And so we're really, roughly at the same level of smoking prevalence that we were back in 2005. We're essentially substituting one tobacco product for another. Now, if we look at Chicago specifically, the overall percentage of Chicago adults who smoke cigarettes is at about 16.8%. And as you can see in this diagram here, this follows the combustible cigarette use rate in Chicago, and the dark blue here is where the rate is the highest. And as we can see, cigarette usage is highest in Chicago's South Side and West Side neighborhoods. Also worth noting is that from 2017 to 2018, reported electronic cigarette usage doubled in Chicago. So let's take a closer look at special populations and their tobacco use. So at the bottom of this graph here, we see that the overall national average of tobacco product use is about 20.8%. But we see that it's significantly higher for men. We also see that prevalence is higher for non-Hispanic, American Indian, Alaskan Natives. We see that individuals who identify as non-Hispanic, other for race, have a higher smoking rate. The Midwest, compared to the West Coast and the East Coast, also has a higher rate of tobacco use. What particularly stands out is individuals whose highest educational attainment is a GED have extremely high rates of smoking, almost over double that of the national average. And we also see that with individuals who experience severe anxiety. Tobacco use is also closely tied to poverty. The smoking rates are higher for people who live in households where the annual income is less than $35,000 a year. Individuals in the lesbian, gay, and bisexual community also have increased rates of smoking, as do people who are on Medicaid or who are uninsured. Both are at around 30%, so about 10% higher than the national average. And we also see high rates of tobacco product use in individuals with disabilities. So, what this chart is really showing here is, the people who are smoking historically are some of the most underserved populations by the healthcare system, and really have a variety of obstacles to accessing effective tobacco treatment. And, that's a really big problem, right? This slide isn't really telling you anything new, right? We know that smoking's bad. It's, linked to over a dozen different types of cancer, cardiovascular issues, dental issues, and the list goes on. But smoking is the leading cause of preventable death in the United States, and it's responsible for an estimated 480,000 deaths per year. And, the frustrating part is we know how to treat tobacco dependence. But we're just not giving people the resources that they need to effectively address it. In particular, so the population that I work with, I only work with individuals who have a history of cancer. And I know a lot of patients with cancer often experience, a great deal of distress because if they were a current smoker at the time of cancer diagnosis, many of them struggle to quit afterwards. And, receiving a cancer diagnosis is an extremely stressful time. And, stress is certainly not conducive to making a quit attempt. But what I really want to point out in this chart here is, we see especially for particular types of cancer, for prostate cancer, the smoking prevalence has increased in recent years. It's also increased for ovarian cancer, for lymphoma. We really haven't made much progress in reducing smoking prevalence for patients with lung cancer, which is a big problem. And though we've made, and also the same goes for colorectal cancer, that's remained the same. And also for cervical cancer, some progress has been made in reducing smoking prevalence, but we still see as many as 1 in 3 patients continue to smoke. And so, why is smoking cessation so important after you receive a cancer diagnosis? The bottom line is that, quitting smoking is a critical part of your cancer care. And, continued smoking after cancer treatment or during cancer treatment, it can interfere with the efficacy of radiation, chemotherapy, immunotherapy. Patients experience a lower quality of life, much of that due to an increase in some of the unpleasant side effects associated with cancer treatment. If surgery is part of someone's cancer treatment plan, it prolongs healing time and increases the risk of surgical complications like infection. Not to mention also, it increases the risk of developing a secondary cancer. And continued smoking after a cancer diagnosis also contributes to the financial toxicity of cancer treatment. And this is a really big problem because we know that the people who are smoking overwhelmingly have lower levels of educational attainment and are more likely to be uninsured or on public health insurance. So essentially, continued smoking makes it more likely that a first-line cancer treatment won't be effective and cancer won't respond to it. And this is what we call first-line treatment failure. And so the average cost is about $11,000 per patient who continues to smoke after a cancer diagnosis. And that's quite a lot of money. Here in this figure, we see that, unfortunately, patients who continue to smoke after being diagnosed with cancer have the worst, survival rates as well. So we know, who is, we know that smoking prevalence is higher in certain populations, right? More research needs to be done on specific smoking behaviors for oncology patients who, are racial ethnic minorities, who also are living with disabilities, who are also living with mental illness. But it's not super difficult to connect the dots between smoking prevalence and continued smoking after a cancer diagnosis and some of the disparities that we see in cancer treatment outcomes. I could do a whole other talk on just this topic, but I do just want to give you the highlights for the sake of time. Black patients have the highest death rate of any racial or ethnic group for most cancers. We also know that, while Hispanic whites have a lower overall cancer mortality rate than the non-Hispanic whites, cancer does remain the top cause of death for the Hispanic population in the United States. We also closely see income or low income as a predictor of cancer mortality. Individuals from low income areas in the United States have a cancer mortality rate 23.6% higher than those living in high income areas. We also know that there's a large tie between tobacco abuse and mental illness. For patients with psychiatric disorders, about 1/3 of their deaths can be attributed to smoking. Their life expectancy is reduced by an average of about 9.6 years due to smoking. And we also observe a 30% increase in cancer case fatality rates for patients both with cancer and with a psychiatric illness. And what these groups all have in common is literature shows that they're all less likely to be advised by healthcare professionals to quit smoking. And this is really, this is unacceptable. When I see a patient with a lung nodule and, I'm the first person that they talk to that's providing them with evidence-based tobacco treatment. To me, a patient with lung cancer who's a current smoker, this is someone with stage 4 tobacco dependence that the healthcare system has failed to address. And ideally, this is something that should be addressed before patients receive a cancer diagnosis. And I'll be honest with you, programs like mine, having a tobacco cessation program built into a cancer center, are not the norm. Most healthcare institutions, don't have a designated team to treat tobacco dependence. And it's getting better. I think we're definitely making some progress. But this is an urgent issue. And, getting that support to implement tobacco treatment programs into the healthcare setting is going to take a long time. So what I really want to do is to be able to give you the tools to begin the journey to quit smoking or help a loved one quit smoking. At the end of the day, sometimes you are your own best advocate. So how do we address this problem? How do we treat tobacco dependence, right? So evidence shows that the most effective way to help people quit smoking is through a combination of pharmacotherapy, so smoking cessation medications, and behavioral counseling. So in order to better understand why we use smoking cessation medications, why they're important, it's important to understand nicotine addiction. And I want to be clear, I think sometimes addiction can be a bit of a loaded term. It can be a bit of a stigmatized term. When I refer to addiction, I'm not talking about, I'm not saying that, someone has a character flaw or some personal moral shortcoming. When I talk about addiction, I am talking about long-term structural, biological, chemical changes that take place in the brain because of exposure to nicotine, okay? And so this is going to be a very brief overview. I'm not going to get super into the neurobiology that's happening here, but the main brain structure that nicotine addiction concerns is called the ventral tegmental area. We call it the VTA for short. And what it does is it essentially integrates information from your environment with your internal state. So, how you're feeling. It has nicotine receptors on it. And when those nicotine receptors are stimulated, it releases dopamine to the nucleus accumbens, which is the part of the brain that drives drug-seeking behavior. And dopamine is really, the stuff that makes you feel good when you light up a cigarette. And also what's important is that the VTA is involved in adaptive learning. So when you smoke a cigarette, there is a little bit of ammonia in the cigarette. You heat it, a chemical reaction occurs. About 35% of that nicotine is turned into free-base nicotine. And this is important because this particular form of nicotine rapidly crosses the blood-brain barrier. It stimulates nicotine receptors on the VTA. Dopamine is released in about 11 seconds after taking that drag from that cigarette. And at the same time, adaptive learning occurs. So if you're someone who, likes to have their morning cigarette with a cup of coffee, or if you like to smoke after meals, or if you like to smoke in the car, what will happen is your VTA will start associating, those, I always say, people, places, things with nicotine and that subsequent release of dopamine. And so it sort of learns these patterns, it learns these routines. And when you don't smoke, so for instance, if you're someone who, likes to smoke when you're in the car, if you decide, okay, I'm not going to smoke in my car today, you might get in your car and you might feel kind of weird, right? You might feel like, what do I do with my hands? You might feel on edge, you might feel anxious, you might feel, frustrated or irritable. These are all symptoms of nicotine withdrawal. And basically what's happening is your VTA is starting to send error signals because, you're in the car, but it's not getting the nicotine it's used to. So it's sending out signals that, something's wrong, something's not right here. And it can be really difficult for people to understand if you're not someone who smokes, like what people are going through when they're going through nicotine withdrawal, and it can be extremely uncomfortable. So this is what we really try to address with smoking cessation medications. So I want to get some audience participation, and we'll do a quick knowledge check. So this is a true or false question. True or false, using nicotine replacement therapy, such as the patch, nicotine gum, etc., is just as bad as smoking. All right, we'll give everyone a second to answer. All right, should we close polling?
Yes, yeah, we can show the results.
All right, good. So the majority of you got it right. The answer is false. So nicotine isn't, so it's kind of ironic. So nicotine is the addictive part of cigarettes. It's not the bad part. Nicotine is not, interfering with the efficacy of your cancer treatment. It's not, contributing to increased risk of developing cancer. It's the other chemicals that are in the cigarette. And so we'll actually sometimes call nicotine replacement therapy, like the patch, like the gum, like the lozenge, we'll refer to it as clean nicotine because it's giving you nicotine without all of the other toxic stuff in cigarettes. So let's do just a really quick review of nicotine replacement therapy. I'm happy to answer, additional questions about this during the Q&A portion, but generally, nicotine replacement therapy it works best when you use it as combination nicotine replacement therapy. And what this means is you would use a form of long-acting nicotine replacement, like the nicotine patch. And the patch essentially provides you with a low, steady dose of nicotine throughout the day to reduce withdrawal symptoms and take the edge off. But it's not going to take away all of your cravings. So when those cravings do come up, that's when it's best to use a form of short-acting NRT. And this would be something like the nicotine lozenge or the gum. And this gives you short bursts of nicotine when you need it, when you encounter a craving, okay? I have some information here on how to access nicotine replacement therapy. I'll also, I think Chicago Check will also send out a tip sheet for everyone afterwards with additional information on how to access smoking cessation medications. So don't feel like you have to like scribble everything down, get all the information down now. And so one thing that I wanted to make sure I address with this is a really common concern that a lot of patients have when starting combo NRT. They'll say, okay, so I have like a 21 milligram patch. I wear that all day. Plus I'm supposed to be using, 8 to 9 of these 4 milligram lozenges. That seems like so much nicotine, right? And so this is a really helpful graph to illustrate just how low the dosage is of the nicotine patch and the gum compared to the huge spike in nicotine that you get from smoking a combustible cigarette. To put things in perspective, when you smoke a cigarette, the surface area inside your lungs is, several hundred square feet. Versus something like the patch, it's essentially a 2 by 2 centimeter Band-Aid with nicotine on it. So, cigarettes are really the most efficient nicotine delivery system. The patch and the gum and the lozenges are absolutely helpful in reducing withdrawal symptoms and making people more comfortable during a quit attempt. But they're nowhere near delivering as much nicotine as you would get from smoking a cigarette. So I always just like to reassure patients of that. Generally, we recommend that, combination nicotine replacement is used for at least 3 months, but your chances of sustaining a quit attempt are better if you're able to use it for closer to 6 months. Okay, so we'll move on to our next knowledge check. This is another true or false. True or false? Chantix will give me mood swings.
All right, I think we can give it maybe 1 more minute and then go ahead and show the results. Make sure you guys get your answers in. Thank you.
All right, should we see see the results? Ooh, oh, almost 50-50 on this one. Okay, good. I'm glad I asked this. So the answer is false, actually. This has been studied extensively. Lots of clinical trials have been done comparing adverse neuropsychiatric events between, we'll have a group of people take Chantix, and then we'll also have a group of people take a placebo or a sugar pill. So what happens a lot of the time is, when people are trying to quit smoking or reduce smoking, they'll start taking Chantix, and they'll start going through symptoms of nicotine withdrawal. Okay, Chantix is something we call a partial nicotine agonist. So it stimulates some of your nicotine receptors, but not all of them. So you will still get some cravings while taking Chantix. You will sometimes still experience symptoms of nicotine withdrawal, many of which can be mood swings, irritability, and depression. So that's generally due to nicotine withdrawal, not Chantix. So how does Chantix work? So sometimes Chantix is also called varenicline, but essentially it blocks nicotine from activating the brain's nicotinic receptors. So if you do smoke while taking Chantix, it reduces the pleasurable effects of smoking because those receptors are already blocked off. At the same time, it stimulates those nicotine receptors a little bit, so you get a little bit of that dopamine release, and it helps take the edge off of nicotine withdrawal symptoms. Generally, the dosage is gradually increased over the first week. The full dosage is reached on day 8. So, when you're at the full dosage, you would take 2 pills, 1 pill in the morning, 1 pill in the evening. The most common side effects are nausea and sleep disturbances. So I always recommend that, if you are taking Chantix, you take it on a full stomach with a full glass of water, and at least 3 hours before bedtime. And if some people do have a little bit of nausea, a little bit of sleep disturbances, generally it's been found that those generally subside within 2 weeks of taking the medication. And then here's some additional information on how to access Chantix, and that'll all be shared with you after this presentation. So final knowledge check question. True or false? It is safe for me to start using smoking cessation medications, even if I am not ready to quit smoking.
So again, we'll give it 1 more minute to make sure everyone gets their answers in, and then we can go ahead and show the results. So make sure you get them in. Thank you.
All right, should we take a look at the results? All right, so 58% say true. And 58% of you are correct. Smoking cessation medications such as nicotine replacement therapy and Chantix can be taken safely while you're still smoking. You know, generally you will find that you have a diminished desire to smoke. But really, you know, the first week or two of being on smoking cessation medications, it's really about getting used to taking the medication consistently, and also just building up your confidence in your ability to quit smoking. And it's, you know, it's okay to smoke while on these medications. This is just a really quick chart here. There are some other medications to assist in smoking cessation on here that I'm not going to cover. The reason for that is generally the nicotine patch, the nicotine gum, and the nicotine lozenge. Those are, you know, generally the most accessible smoking cessation medications. And varenicline is one of the most effective. So Chantix and combo NRT are generally considered the most effective medications to go on for tobacco dependence, and they're generally the most readily accessible to most people. But what I really wanted to show is, you know, using a smoking cessation medication, whether it be the gum, the patch, the lozenge, really increases your likelihood of a successful quit attempt. Chantix, you see here, actually more than doubles the chance of a successful quit attempt. So that's, you know, really, really encouraging to see. So motivational interviewing, right? So this is the part where if you're trying to support a loved one in quitting smoking, this can be, you know, these are some really helpful tools. So this is a type of behavioral counseling that I use every day in, you know, in interacting with patients. And its evidence shows that it is the most effective form of counseling to help people quit smoking. And it's really about establishing a connection with someone, exploring their feelings, beliefs, their values, right? What are their motivations for quitting? You know, maybe not just getting through their cancer treatment, but maybe they want to spend more time with their grandkids. Maybe they're worried about the effects of secondhand smoke on their family, on their pets even. And of course, motivational interviewing is supposed to be motivational, right? So the last thing you want to do is scold the person or use a judgmental tone with them. And I know, you know, if you're trying to help someone quit smoking, it can be so frustrating, right? And you know, it can be very tempting to sort of, you know, put the heat on them to quit smoking. And it comes from a place of caring, but you know, when we use a scolding or a judgmental tone, it's really not constructive. So, you know, the goals for motivational interviewing are really, you know, identifying their motivations, you know, understanding how this relates to the person's values, and building up their confidence so they can make a quit attempt and hopefully stay quit. So there's, you know, kind of an acronym we like to use called ORS. And I'll follow up with some examples. So asking open-ended questions, you know, how do you feel about quitting smoking? Affirming their strengths, right? Like, you've done such a great job reducing so far. You know, I know you can keep going. Reflecting back comments, right? It must be frustrating that you feel like, you know, everyone's on your back about quitting smoking. And finally, you know, summarizing the discussion. You know, here's what I'm hearing from you, and you know, and here's our plan to tackle this. So these are just some examples, because I think it's really easy for people to struggle with, you know, what do you say to someone who's trying to quit? You know, so asking open-ended questions like how they're feeling. So, you know, if someone's trying to quit smoking and they say, I have a headache, I'm in such a bad mood, you know, encourage use of smoking cessation medications. You know, do you think, you know, maybe using a lozenge might make you feel more comfortable right now? Affirming their emotions. You know, people are allowed to be upset, you know, particularly after a cancer diagnosis. And then also, you know, reeling from that while still trying to quit smoking is extremely stressful. You know, so it's okay to say, you know, it sounds like you're under a lot of pressure. That must be stressful and frustrating. It's important to acknowledge that so they feel heard. Also congratulate them on their progress, right? You know, if they reduce, tell them that's fantastic. Don't criticize them for continued smoking. You know, encourage them to keep going and affirm their progress. And also just sometimes asking them how you can help. And encouraging self-care can really go a long way in supporting someone. So, you know, planning activities together, or like taking a walk, right? It's a distraction, and also it encourages physical activity, can reduce some stress and anxiety. You know, celebrating, you know, small wins in their progress. Or just asking, you know, is there anything I can do to help reduce your stress levels right now? Can be immensely helpful. And finally, you know, not all of us are full-time behavioral counselors, and that's okay. So one of the best things that you can do is help the person identify triggers and direct them to resources that help them build a quit plan. And you can also connect them with free behavioral counseling and external support. So, you know, at the conclusion of this presentation, I think a tip sheet will be sent out to all of the attendees with some specific resources on accessing medications and counseling, and some websites and free text mobile resources as well, for you to utilize and take advantage of. So with that being said, you know, thank you everyone so much for listening to me ramble on here. I'd like to, you know, open it up to any questions.
Thank you so much, Sarah. We really appreciate you sharing all of this great information with us. At this time, I think that we're going to be unmuting folks so that you can go ahead and voice any questions you have. But I did see that we did have one question in the Q&A. And that is nicotine found in the inside of cigarettes or also in the wrapping of cigarettes and cigarette products?
So that's a good question. So tobacco contains nicotine. So, you know, the wrapping of a conventional cigarette is paper. So I would imagine that there isn't nicotine in like the white paper that wraps the cigarette. If you're smoking something like a cigarillo or a cigar, that's wrapped in tobacco, and so that wrapping will have some nicotine in it because it is tobacco.
Thank you. Did anyone else have any additional questions? Feel free to unmute yourself and voice them if you'd like.
I can ask a question. Thank you so much for your presentation, Sarah. I have a question about the smoking cessation medications. So after you quit, is that something that you'll have to continuously take for years after you quit? Or is there a point where you don't have to take that anymore?
Yeah, so I love this question. Such a good question. So basically, we've done a lot of animal studies, and particularly on rats. And so what they do is, you know, they expose the rats to cigarette smoke with nicotine in it, like to mimic, you know, a smoker's brain. And then they take the rats off of the cigarette smoke. And so what they've done is then they test to see how many nicotine receptors the rats have in their brains still. So what we find, if you're someone who smokes, your body becomes accustomed to high, you know, levels of nicotine, and it responds to that by actually making more receptors for nicotine in your brain. And the good news is that eventually the numbers of those nicotine receptors do go down. The tricky part is that the animal studies show that your body doesn't start down regulating the number of those nicotine receptors until you've been quit for about 3 months. So you can have not had a puff of a cigarette in 3 months. And then, you still might have some cravings to smoke because you still have an overabundance of nicotine receptors. So that's generally, minimum amount of time I would say, that's recommended for smoking cessation medications is 3 months. If you're still smoking, absolutely, continue those medications. Generally for my patients, I say, minimum 3 months, but even better if you can do 6 months, because that gives your body time to down-regulate those numbers of nicotine receptors after you've been quit. And it does increase the chance of a sustained quit attempt. Being on smoking cessation medications for years, I wouldn't say, you have to be on Chantix or the patch for years and years and years. That being said, nothing bad's going to happen if you wear the patch for longer than 6 months. That's fine. The goal is eventually to wean yourself off of those medications. Chantix can be used, usually it's used for about 6 months, but you can actually use it for for a year or longer if you feel that it's benefiting you. So I hope that answers your question.
It does. Thank you so much.
So I see we have a question in the chat. It says, does hookah contain nicotine and can people become addicted to it?
Yeah, so hookah does contain nicotine, absolutely. Hookah is a little bit more of I think there's definitely more of a social element going to the hookah bar, but there is nicotine in hookah.
Thank you, Sarah. I do have another question. So what if you have a close family member or a friend who is a heavy smoker and they have no interest in quitting anytime soon? Do you have any suggestions or feedback on maybe how you could approach smoking cessation topic with them?
Yeah, that's a great question. So there's a couple different things that you can do. One of the questions I like to ask people who are, really, really reluctant to talk about quitting smoking is, you don't have to start the conversation with quitting smoking, right? I'll start and I'll ask them, what do you like about smoking? What are they getting out of it? Is it a form of stress relief? Is it a coping mechanism? Even just that tells me important information, because I know if someone is smoking to cope with stress, it's important for me to find other ways for them to deal with stress, so they don't feel that they have to rely on smoking as much. So you can ask them, what they like about smoking. You can also ask them, is there anything that you don't like about it? And it doesn't necessarily, I think it can be tricky to frame smoking positively for some people. And, another exercise is, okay, picture yourself in 3 months. How would your life be different if you quit smoking? So you don't have to tell them anything, but you can ask probing questions or strategic questions to better figure out, the reasons they smoke, and, maybe start to identify some motivations and some values that could push them in the direction of eventually reducing or quitting. Sometimes as well, you can simply say, you know what, you don't have to quit smoking. Don't even worry about that right now. All I need you to do is wear the nicotine patch, see how it goes. And generally, after wearing the patch for about 2 weeks, that person may find that they feel more confident in their ability to start reducing smoking, and they may begin to feel less defensive when approached about the topic of smoking cessation.
Great, thank you. Another question that we received is, I smoke when I drink. Do I have to give up alcohol?
Oh, that's such a common one. Yeah, so I would say, so this is, alcohol, right? Really common trigger for smoking. Absolutely. The one tough thing about alcohol and tobacco use is when used together, the cigarettes amplify the carcinogenic effects of alcohol, and the alcohol amplifies the carcinogenic effects of cigarettes. So, you know, uh, using alcohol and tobacco at the same time, so that, it does sort of it's not great for, just in terms of, increasing your risk of head and neck cancers. So that's always something, to be conscious of. Generally, if alcohol is a trigger for someone, I do recommend abstaining from alcohol for the time being. And, if you are able to successfully quit smoking and you do want to drink socially in the future, then, once you feel confident in your ability to stay quit, once you've learned the coping mechanisms to be able to handle those high risk situations, that's when you can start gradually introducing alcohol back in. But if you have a slip, the best thing you can do is learn from it. So then, it doesn't happen again in the future.
Thank you, Sarah. We did have a question in the Q&A. It says, thank you so much for your presentation. I wanted to ask if you are aware of any work being done to help encourage different types of healthier coping mechanisms for people who primarily use smoking as their main coping mechanism.
Yeah, so that's something that, that we really that we address. Most people who use tobacco, they're more likely to experience feelings of anxiety, sometimes feelings of depression. So, oftentimes they use smoking as a coping mechanism to deal with these feelings. And the one thing that I tell people is, research shows that if you're someone who suffers from anxiety, if you're someone who suffers from depression, quitting smoking actually reduces the severity of symptoms from that. The reason for this is, so you smoke a cigarette, they're huge, hit of dopamine in 11 seconds, you enjoy your cigarette. About a minute after you put that cigarette out, your body's already beginning to go into nicotine withdrawal. And this contributes to a general sensation of uneasiness, of irritability. And that can absolutely amplify, feelings of being stressed out or being anxious. So I would say, the best thing you can do is really, use smoking cessation medications to reduce symptoms of withdrawal. You don't have to quit smoking, as soon as you put the patch on, but you'll likely find that you feel more comfortable. And if we do have if I do have a patient with, who has clear signs of, of clinically significant anxiety or mental illness, or needs, really more intensive therapy to develop those coping skills, then, I would absolutely refer them to psych.
Thank you. I know, just to be mindful of time, we've got 2 more minutes, but I did see there was another question in the chat. So Arceli says, is there any advice you have for young adults or career changers that might be interested in working in your field? How does one become a behavioral counselor?
Oh gosh. So yeah, there's a lot to unpack there. Is there any advice? I would say, go into it with an open mind. I think we all have implicit biases, and I think addiction is heavily stigmatized, and it often overlaps with, with class, with social status, with race, ethnicity, mental illness, disabilities, and the list goes on. So for me, it's been a really eye-opening experience, just, you know, in my clinical work and the training that I've received in challenging some of my implicit biases, you know, that I didn't even really realize that I had until I began in this field. I started working in tobacco cessation. I started as an unpaid intern in preventive medicine, you know, helping out with a postdoc student's research study, and then I transitioned over to supportive oncology, and I started just doing outreach for our program, and eventually I became a behavioral counselor. So there's no one way to get into the field. Tobacco cessation, I think it's growing, but I will say, you know, our program is funded by grants. There's currently no pay code for tobacco treatment specialists to bill, so that can make things, it can make it a little bit of a tricky career, because you are still sort of relying on grants a lot of the time as a tobacco treatment specialist.
Thank you. I appreciate that. So we are at time. So I did want to be mindful of everyone's time, and thank you very much for everyone coming out today and joining us for our virtual community conversation. Thank you, Sarah, for sharing so much of this wonderful information. I know I've definitely learned from it, so I'm very grateful for that. Stay tuned to everybody that had registered and is on the call. We will be sending out that informational sheet Sarah was mentioning, so that you guys will have all of these resources on there as well. If you have any questions, I believe Sarah had put her information up earlier. I'll also just share my screen really quick with some information just for a check if you have any questions for us too. But if not, I give you guys the rest of your afternoon, and thank you so much for joining us.
All right, thanks everyone.
Bye, take care.